Thank you for that introduction, Adam, and it's a delight to be with you, Roger, to share this podium. And I'll first acknowledge the traditional owners of the land on which we're meeting, the land of the Gadigal people of the Great Eora Nation. And when I do that, I'm always aware I was born on Gadigal land and seem to have spent most of my life and keep orienting back to Gadigal land. So it has increasingly a lot of meaning for me. And acknowledge elders past, present and future. Gary Banks was very helpful to us in preparing these sessions. He's didn't just get a bunch of people and say go and talk about something that might be of interest. He sent us some guidance and expectations, and for this health session, his thoughts were, and it's reflected in the program, that he wanted to use health as an exemplar about dealing with disruption. And he asked us to consider the experience of, from his perception, sitting outside the health system, of constant change and disruption in health over many decades, and how this might be useful for other parts of government, and asked that we connect our own experiences to the challenges of contemporary public management. And as somebody who worked in public management in the 70s and 80s, in fact started in career, and then was in the private sector for 20 years and came back into public management for this role, which was very much a health role using my specialist background in health, though I absolutely drew on all my training in public administration that came before that. I found this a very interesting assignment, recognising the audience is mixed. I know I have some great health colleagues here, but also people who are not health, to actually step back from what we all know is often a very highly specialised subject matter of health policy and management of health services delivery, and look at the experience of our sector over the last few decades from a generalist perspective of public administration, and to attempt to discern any transferable lessons. And notice I haven't used the word learnings. I've read Don Watson's book and others where, how we sort of obfuscate with managerial language when there's a perfectly plain and simple language to be used. And some of this goes to trying to unpack complexity in our system, and I'm happy to come back to that. Or at least, if I can't do that, at least to the extent health has been successful, and there's still many challenges and many ahead, to the extent a sector has been successful in dealing with disruption, what have been those more general characteristics of that success? And therefore, we in health, what do we need to do to meet the further disruption, which is absolutely and certainly lying ahead for us? So I thought it might help just to, let's start by looking at the sources of disruption in health over the last 30, 40 years. And I'm sure all of you health people in the room could rattle off a comprehensive list of these factors, and indeed there is increasingly global consensus about these issues. There's huge convergence in terms of healthcare issues and challenges which affect all health systems, and there is a global search and global cross lessons in the global search for policy solutions. But to explore this today, I thought for our purposes, I think we could consider the disruptors. If I turn our language in health into thinking about, well, what are these key disruptors for us in our sector, I felt they could usefully fall into three main headings. The first two of which have been with us for decades and which we continue to develop, innovate, problem solve and use to adapt and advance health systems. And the third is emergent, and the one that's really coming at us and presenting a whole new set of challenges today, both here in Australia and globally. It's the global conversation in health. So the first one of these first two that we've had for decades is the continuously accelerating demand and costs of healthcare, which we all know about. And people love to say that, if it keeps going that way, or the entire health budget of New South Wales will, end up going to health and crowd out everything else. Health in New South Wales currently accounts for 27-28% of the state budget, for example. And of course, all developed countries have systems which seek to ensure affordable, accessible healthcare for all citizens, not dependent upon the individual's ability to pay. That's achieved in various ways through both direct government expenditures and or regulation, and with most OECD countries, health systems use a mix of these things to deliver that outcome for citizens. And it's an expectation for all citizens. We're not talking about safety net or whatever. Health is one of those things. It's essentially you've got to have a community good of an insurance principle of to pool the risk and pool the funding and pool the access. There's lots of ways you can do that, but it's a whole of population arrangement rather than some of the other challenges that we need to interface with, which is picking those people that need extra support or extra health. Not that we don't have to have that lens in health too, but it is fundamentally different in policy thinking terms, which is often why health folk and other social policy folk sit down together. We often clash and we often are at cross purposes with quite different assumptions. And you have to understand that to start to join up the dots. For the benefit of citizens. For decades, health expenditures, which I've measured globally as public and private expenditures, typically grow at a rate greater than GDP and have done so for decades and continue to do so. And at 98% of GDP now, Australia's health expenditure is close to, but on the modest side of the OECD mean. And at the same time, on many measures, it's indicated that we have very, very good health outcomes for that modest mid-range investment. And longevity is one. It's always the first indicator you look at, and we're in the top 5 countries for longevity. And in our lifetimes, even just in the last 10 and 20 years, our own life expectancy has significantly increased. It's which is just extraordinary. These aren't big, long-term population changes. We're actually experiencing them now. And just another example, earlier this year, AIHW brought out a report on the burden of disease, which finds that Australia has, in the 10 years it's covering, that Australia has reduced the disease burden by a measurable 10% over a decade, which is extraordinary. So these are just some of the practical measures. Not that we want to sort of be complacent, but you do have to get into perspective that in terms of having an affordable, accessible and effective healthcare system, we have many of the elements and a great platform. And indeed, when you give some of these metrics in international context and sort of are wringing your hands worrying about your issues, and I had this once when ANZSOG had me present to a visiting Indian group of very senior officials. They said, "What's your problem?" That's fantastic. You're doing so well. How do you do it? So I keep having to remind people of that, because otherwise, it's very bad to go to despair and just think the problems are either unique to the ones we're facing and come down to personalities or failures. They're systemic in the nature of the sector globally, and also that in fact a great lot of great things are happening, and the reason we have a good health system that the community holds us so accountable for is because both in the way we've organised healthcare, both publicly and privately, in policy and funding and delivery, there's a lot of things that have gone very well to be able to achieve what we achieve, at the same time as there remain many, many challenges and huge disruption ahead. A key driver of demand, so we're still in this category of accelerating demand and costs, decade on decade on decade, it's inexorable. A key driver of demand is ageing populations, who have a supercharging effect on the demand for healthcare, which is easy to understand. And if you just take the New South Wales population projections, which we'll soon update with the next census, but you'll see that people 70 and over will increase as a proportion of the New South Wales population between 2011 and 2032 from 10% to 15%. So that's a very big increase in the proportion. And we all know about the challenge of ageing populations, and we heard some of the demographic stuff yesterday. And this translates on current models of care to projecting out to an increase for public hospital beds in New South Wales of these cohorts requiring not 43% as they do now of our hospital bed days in the public system, but 56%. So it's a huge driver of the utilisation of the part of the healthcare system, acute public hospitals, that states are responsible for. So you can see how that driver has been there and having to be dealt with in health for a long time, and continues and will accelerate even more as this baby boomer generation that I'm part of start to move through into old age. The second, and these are all related, that's why I tried to just group them into three headings, is health technology. And a lot of times when you say that, people either think digital technology, yes, it's heaps of what we face and will be disruptive like in any other sector, or otherwise they think of machines that go bing. But it's actually how we actually do healthcare, how we actually do medicine, and the science behind it and what we're able to do. It's fundamental to what health service delivery is all about. And indeed prevention as well. A Grattan Institute report, which on the drivers of the expenditure drivers for future budgets for all combined Australian governments, identifies health as by far the biggest driver of government outlays going forward. Just beats the pants off everything else. And the report also usefully identifies, and this is in other texts, but they're not alone to do this, but they do it in an interesting way that quite graphically hits you in the face, that their report also identifies that the biggest driver of government health expenditures, and this is the case in health expenditures generally, but they've taken all that government health expenditure and done some analysis of it in the period in the 10 years to 12-13, and show that, in fact, for want of another term, the technology effect is actually more than twice as much in terms of driving the growth demands as population growth combined with ageing, combined with health inflation above CPI. So if you can picture that, you sort of got a graph that says, this much for those three factors, and then this much for, on top of that, for the health technology effect, which is that growth demand is actually that there are day after day, week after week, year after year, simply more new and improved treatments which can be offered, and it represents more services per person across all age groups. And while people are quick to go to saying, where there's supply-driven demand, over-servicing and so on, this is what means that, we're not sitting in a old age home with a rug over our knees in our 60s. This goes to why our children with cystic fibrosis or leukemia actually get to survive childhood now. There's just so many different aspects of this, and it's feeding into that outcome measure of longevity. And this is just happening all the time in healthcare, and it is such a huge driver. Atul Gawande, who will be well known to those of you in health, as an American clinician, does a lot of thinking, talking and persuading in this space, especially with clinical colleagues, to try and turn the world of medicine that they've been trained in to reorienting to think about these future challenges. Atul says there's not a country in the world that's not asking whether we can afford what doctors can now do. We have gone from being able to treat a very limited number of conditions with a very limited number of largely ineffective treatments to now being able to treat almost all of the tens of thousands of conditions that might present. The treatment for severe arthritis has evolved from aspirin, largely ineffective and inexpensive, to hip replacements, highly effective but much more expensive. In the 1970s, it took 2 clinicians to look after a patient in hospital. It now takes 15 on average. So you've just got this, I described ageing populations as supercharging, but it's nothing compared to that technological push. So while new technology absolutely fuels demand and costs, and the pressures on government, and that's a pressure on whether it's direct government expenditure or coming up with the appropriate public policy to ensure that people have access by whatever means, and there's all sorts of ways of putting that together. But it also produces solutions. The new technology is supporting more standardised processes of care, which look to measure and reduce unwarranted clinical variation. This is driving approaches of development of protocols, smart digital systems for decision support around those protocols. even say just guidance on prescribing, for example. Methodologies for, again, often digitally supported for shared patient decision making. Payment models, such as penalties for inappropriate readmissions based around effective utilisation of health data, feeding that into the payment models. So at the same time, but interestingly at the same time, so this is about reducing unwarranted variation. And of course, everybody looking at these growth pressures is hoping that'll sort of bend the demand and cost curve a bit. But at the same time, the new technologies are also driving not just towards standardisation, but to what's called precision or personalised medicine, which has the also potential cost savings by avoiding standardised protocols and having sort of one-size-fits-all approach, where the genome may indicate that treatment won't work optimally or at all for that individual. So again, that's got inbuilt driving efficiencies around how we approach these new capabilities, but then there's the cost of introducing and working out the optimum application of emerging genome technology, and we could go out tomorrow and suddenly say, we could say. Federal government could suddenly find people saying we've got to have an item on the MBS, and we should all have our genomes done. So a very, very expensive proposition, even with the price of those genome analyses coming down to about $1,000 to $1,500 a patient. So and of course. All of these developments are affected, enhanced and disrupted by the increasing take-up and utilisation of digital technologies in and around all of this. One very measurable benefit of technology in both quality and cost is over the last decades is the significant and continuing reduction in length of acute hospital stay, and this has been happening over at least 4 decades, if not more. More effective treatments emerging through that technological push mean that admissions are shorter and shorter, and many treatments can actually be provided on an ambulatory basis, which means, for those not familiar with the health jargon, on a clinic walk-in, walk-out basis, where once upon a time long hospital stays were required. If we were still providing, in terms of the capital planning and infrastructure planning in New South Wales, we often sort of explain to government that if we were still providing the models of care that we did 10 or 20 years ago, we would need to be building a new Westmead hospital a year to cope with that. Now, while all state systems struggle to keep up with the demand for capital infrastructure, we don't have, if you sort of had the models of care we had 20 years ago, you'd have a hospital on every corner, to try and cope with that. But we do healthcare very differently. So there has been this huge adaptive use of technology to moderate the way we deliver, at the same time as it also keeps driving this huge inexorable demand at a rate greater than GDP. Of course, I know if Henry Ergas was here, he would also say people don't get upset when, as economies grow in their wealth and people want to spend more money on flat screen TVs. We don't go around wringing our hands. We might think about, maybe we should invest in flat screen TVs. But when one of the things that communities do is, as their economy improves, they, surprise, surprise, want to invest more and more in healthcare. And why wouldn't you? Because it goes to some of the most fundamental things about, life and wellness and being on this planet. So it's there's another whole talk one could give about, it's not just all gloom and doom, but it is a real challenge when you've got these super drivers that we've been dealing with to date, but are just going to go even harder into the future. And so they're the two big ways that I think of usefully thinking about what have been the disruptors and the adaptations we've had to make for 30 or 40 years. And I'm old enough that I've been around for most of those. Our health systems, the third one is the emergent one, and that is that our health systems here and globally are the victims of their own success. And that success has been in attacking and reducing morbidity and mortality from acute illnesses. And it means that there's been this huge shift that we talk about, the shift in the burden of disease from acute to chronic illness. So that the systems we built, that means you don't die, we'll save you from dying from a heart attack in your 50s or 60s and get you through to old age, and then you have to start to deal with emerging chronic illnesses, but you're having a longer life, and hopefully with a lot of things we can offer a much better quality of life than your antecedents did. So the systems we built in the second half of the 20th century have done a fantastic job, but they're not well designed to manage chronic disease. And the holy grail globally is the quest to define and implement new models of care which integrate around the patient across sectors. And you can see how this starts to, when you sort of step back from us being deep in health language, how this is actually a common theme in this conference about trying, and if we listened to the New Zealand Deputy PM yesterday, about, and certainly here in New South Wales with Premier Baird, and it's a global thing of how to join the dots across all these services to have more effective approach with targeted population groups. So the holy grail globally is to find new models of care which integrate around the patients. The fault lines are how do we get hospitals and primary health care to come together, and they're oil and water. It doesn't matter whether they're all in one public system or they're in different systems or differently remunerated, similarly remunerated, however it's done. These two sectors are very, very different and traditionally oil and water, and how to actually get them to work together in practical ways and effective ways is one of the design challenges everybody's working on. Health and aged care, health and social services. And also how you actually bring the whole area of population health considerations and risk factors for ill health, such as diet, medications compliance, smoking and those things, which have tended to sit off over here in public health, population health land, actually bringing them in and providing them in the health delivery space to improve outcomes. So these are the new connecting points, and we just don't have the models. And not only that, but the sorts of people that have been very good at designing, delivering the systems that have worked to date probably don't have the core skill sets to operate in this area. So that's a big challenge. This involves population and public health approaches, which develop algorithms to look at whole populations and risk-select individuals who would benefit from a more integrated approach. And then, even more importantly, to seek out these patients and offer to enrol them in a program or to an intervention. Say it might involve GPs and hospitals working together, and certainly here in New South Wales we're having a lot of experiments with that, and now it's also being rolled out in national policy. We're starting to see new roles emerging, case managers, care navigators. We still don't really know whether they're a solution or a symptom of the lack of integration. This is a very different model to the acute delivery model, which, as I say, we developed in the second half of the 20th century, where providers wait for patients to present themselves because they feel they've got a problem and need to present themselves when they've got a specific issue. In this one, we use all the population health ones that we actually find out who they are, we find out where we live, and we give them a call. And maybe even connect them up to a computer program or give them a laptop or something. Very, very different way of thinking. Whether it's accountable care organisations as part of Obamacare, whether it's local health integration networks in Ontario, whether it's the latest holy grail going to save the NHS effort around Manchester to sort of integrate health and social services. This is we're all trying this. And one of the most important things in this is to build in the feedback loops to actually, because there's no right answer yet. And one of the things I observe in government is we tend to be too quick to go to the solution and want to plug it in with really understanding the data. In our own experiments in New South Wales, and this happens globally, I've seen it in countless documents, everybody has their intervention of this nature, measures it, and surprise, surprise, whether it's a very simple intervention or a complex one, whatever it is, they all get about 30 to 40% reduction in a key outcome everybody wants, which is reduced hospital admission, because then that's going to save the money. So whatever benefits the patient might have got by better coordination and tailoring of their care, this tends to be the measure, and everybody says, isn't that fantastic? But then if you actually look at the studies where a control group of some kind has been put against that, you often find that all you're measuring is regression to the mean. screen, or if you just think of the logic of it, these algorithms tend to pick up somebody with an acute exacerbation. So they might, so unless they die in ICU at the most acute end of that exacerbation, we don't keep people in ICU forever. They actually have some improvement and get better and then come out to another level of functioning, and hopefully, go for quite a while before they have another reason to acutely, say, present in an emergency department. So you have to really understand what you don't know, and you have to, this has been talked about over the last 2 days, you really have to build in these feedback loops and not just get religion about the latest fad or intervention. You've got to rigorously know your data, very good execution and very good feedback loops. The multi-million-dollar evaluation, sometimes that can be very useful, but you've got to know that that's why you're doing it. But these ones where we put in evaluation and a long time later an answer pops out and you've had 3 years of a program, we really need other methods where you've continuously got feedback loops and abilities to challenge, ask questions, and think about how, it is, that saying that you're building the plane as you're flying it. So what are some of the characteristics in health? And I'll go through these quickly as just topics which we might want to talk out on the couch. I think some of the important things is to thinking about, now coming right back to this country, and what are some of the things that have made us successful to the extent we have been in dealing with some of these challenges. One is that I think in health, both at federal and state level, we tend, and particularly state level, we tend to come to the policy issues and the problems as a system rather than as a series of programs and government interventions. And that's because health is all about creating a whole of country system, whatever it is, whereby its citizens are supported to access healthcare and where their state of their finances or knowledge or anything else isn't a barrier. We are a very complex system, public and private elements, public and private payers, public and private providers, federal and state governments. And if you move any one of those elements, it has flow-on repercussions for everyone else. And so the simple, let's get the latest fad, latest program, let's just manipulate that and plug it in. Frequently governments get what they don't like, and also it feeds into at a more general level, why people say, people try these things and they don't work. The system focuses particularly well understood at the state level, because states directly own and deliver public hospital and related services, and in fact are arguably the only part of the Australian health system, in fact they really are, that are actually organised and run as a system. And so the state systems, even though they're just a bit less than 50% of the total healthcare system of Australia as measured by where the dollars are spent, act as a kind of backbone to then all the other bits that are critically important. So, and as an integrated network, we have touch points with all the other services. So state policy making is constantly being informed by the experience of operating a large delivery system, which will quickly tell you if you are getting it wrong. Of the 140,000 people who work in New South Wales Health, fewer than 1% are public servants, trained in Westminster and advising governments and knowing how to do that stuff. That's a mystery to everybody. The rest of that 140,000, it's a mystery. And that's fine because they've got other things to do. So those public servants are in the Ministry of Health. The rest are public sector employees, clinical and administrative, who have thousands of patients coming through their doors every moment of every day. This creates a very close nexus in health policy in this country between the policy workers and the front line, and ensures a large pool of highly qualified experts are available to advise and supplement the bureaucracy at all times in a very safe way, so that as a state health head, my employee doctor over there is also the professorial leader of that university's program and also the leader of that Medical Research Institute's research program, and is also on the PBAC Advisory Committee of the Commonwealth, and also readily has the ear of ministers and prime ministers and so on if they want to put that independent expert hat on. And so we've got that built into our system, and I think in health we don't appreciate how that's just a standard way we do business. So what we've been talking about in the last session before morning tea about reaching out, partnering. We can't have all the answers. Health has within itself, and Roger's talked about we need to also look outside, that kind of flow into the bureaucratic context, because most of what we do, while it's called government and measured as government employees, is not bureaucracy. And I don't use bureaucracy as a pejorative term when I say that. And as I say, this feeds into the national picture, particularly through another institution in this country, which I think is interesting from a public administration point of view, which is a long tradition over decades, no matter policies, governments have come and gone, of the health ministers, the name changes of that group, but it has a long continuity, and RMAC, the senior officials that support it. And over many decades, there's been more cooperation than conflict. And there's huge chunks of how healthcare works in this country that have actually been achieved through those mechanisms, and yet those mechanisms are not legislated, they're not mandated, they're not even written down somewhere if you want to look at how they work. But how blood products work in this country, in the end it all has to come back into individual sovereign governments' jurisdictions and be implemented. But the coming together, the design, the consensus, the thinking it through, major NGO, the Red Cross, the Commonwealth's role in funding and bringing it together, the states in getting blood for their own systems but also looking after blood for the private sector, all those players has come about, and it's not legislated, and you'd be hard-pressed to find it all written down exactly how it works or where it is. But whether a pandemic response, how we beat AIDS in the 80s, there's a long tradition of us being able to respond in this way, and also we tend to mobilise in that forum to feed into central agencies when there's big Commonwealth state negotiations. I've got it, Adam's winding me up. The other issues that have been part of our journey in the most recent times here in New South Wales and in health is the availability of data, developing that into effective KPIs, not being swamped by data, making sure our people have the literacy and the numeracy in the data, and that's helped by the, it's a very scientific field, so people are used to dealing with data. Transparency of the funding model and the huge reform piece around activity-based funding, which has largely been under the radar but hugely successful in making the system transparent and being a tool which supports people at the front line, as much clinicians as people who are in management. Devolution of decision-making combined with transparent accountability, and particularly the development of capability and culture in our people. And we've done a lot of teaching in New South Wales over many administrations, not just while I was there, we've got thousands of people through our system now who've done some version of lean thinking, quality process improvement, Six Sigma and that kind of thing, so that they're actually given tools about how they can change their own workplace, whether they're a nursing unit manager, a senior medical clinician, and so on. So I think it's interesting to see that when I reflected on what some of the key things have been and what some of the key elements are, they have been coming up in the more general conversation. So while at first I thought, oh, health's very special and very complex, I'll try and think, Gary, about how to generalise that. The discipline of doing that made me realise, one, that there probably are things where some of the things are being talked about, there are working models in health that could be learned from. But on the other hand, also very clearly, there's lots, as we face the future of designing this health system of the 21st century that's going to look nothing like the one we've had so successfully in the 20th century, that there's a lot we can learn from everyone else, both within government and outside government, and that's the future challenge for us. Thank you.